Well, good afternoon, everybody, and for some of us on different time zones, good morning. Thank you for joining us for today's Quality Forum, which is going to be on happier, healthier patients through pharmacist-led disease management. We're extremely excited to bring you this highly anticipated presentation with our experts in this area. My name is Jake Geldo, and I serve as PQA's Director of Education and Program Development. It's my pleasure to moderate today's presentation, but before introducing our speakers, I'd like to call your attention to a couple housekeeping items. First and foremost is our logistics. Please send us your questions. Use the questions feature in the control panel, and your questions will come to me, and I'll be able to share those with our speakers today. Additionally, our forum is being recorded, and a copy of the slides and slide deck will be available on PQA's member resource library within a week. And as always, please give us your feedback at the end of today's presentation. As a quick note, we'll have reminders at the end of today's presentation as well, but our next Quality Forum webinar will be Thursday, October 3rd, 2019, at our usual time of 1 p.m. Eastern. Additionally, don't forget that our PQA Leadership Summit is coming up this November, the 20th to 21st in Arlington, Virginia, and we'll also be having a pre-Leadership Summit forum focused on social determinants of health. But at this time, it's my pleasure to introduce our speakers. First, we have Dr. Teresa Hodgkins, PharmD, BCACP, and she joined Desert Oasis Healthcare in 2005. She initially served as Director and then Administrator of Medication Management Services, developing and implementing innovative collaborative practice programs for a large medical group. Programs implemented for population-based health management include anticoagulation, hepatitis C, diabetes, infectious disease, coronary artery disease, and high-risk geriatric medication management. Currently, Dr. Hodgkins is the Vice President of Clinical Quality Initiatives at DOHC, so the Desert Oasis Healthcare, and is tasked to provide organizational leadership towards the attainment of key quality benchmarks that are set nationally and publicly reported, like our CMS STARS programs or HEDIS programs. Previously, Dr. Hodgkins spent many years at Desert Regional Medical Center in various leadership positions promoting interdisciplinary team-based care for special patient populations. She earned her Doctor of Pharmacy degree from USC, I believe that's supposed to be California and not South Carolina, where I'm closer to, and completed her residency at Hoag Memorial Hospital in Newport Beach. She is passionate about the profession of pharmacy's important role in leading healthcare system to achieve the triple aim goals of high quality care, lower cost while improving patient care experience. Next, we have Dr. Lindsey Valenzuela. She joined Desert Oasis Healthcare in 2007 as a clinical pharmacist. She's currently board certified in advanced practice pharmacist and is currently serving as the administrator of population health and prescription management, PHARM. I guess that or possibly PharmEx. We'll ask her how to say that officially later. Dr. Valenzuela attended the University of California, San Diego, then received her doctorate of pharmacy at the University of Southern California. She later completed her residency at the Desert Regional Medical Center. In addition, she's board certified in Ambulatory Care Pharmacy. She served as the senior management team for the California Society of Health System Pharmacists Seminar Conference and Medication Therapy Management Task Force for that society, and has spoken for the California Pharmacists Association, Heritage Provider Network, contributed to the California Journal of Health System Pharmacy, and was twice named Preceptor of the Year by Loma Linda University School of Pharmacy. She currently oversees 26 full-time pharmacists and the clinical structure for population health prescription management as it pertains to all of the Desert Oasis Healthcare collaborative practice initiatives, cardiology, and health education. She provides oversight to the team interacting in direct concert with the myriad of primary care physicians and specialists providing care to patients. In addition to these duties, she's also the pharmacy director for the PQA 1 residency program, as well as an assistant clinical professor and preceptor to the robust and ongoing in-house training program placed by Loma Linda University School of Pharmacy and Keck Graduate Institution. So Teresa, Lindsey, the floor is now yours, and thank you so much for joining us today.
Thank you, Jade, for that introduction. Very much appreciate it. Lindsey and I are happy to be talking about a topic that's near and dear to our hearts, that we have a lot of passion around, and that's telling our story of how pharmacists can impact patients in a positive way in a health system in ways that they might not be present in many areas around the country, and we just hope to be an advocate to demonstrate the value and role of pharmacists in these areas. So let me tell you a little bit about Desert Oasis Healthcare. I think, Jake, we could go to the next slide. So you know that we are in California, in the desert, in Palm Springs area in Coachella Valley. We have a high amount of seniors in our area, so at our medical group, we have employed physicians as well as an independent physician association of doctors that we contract with. We have about 100 primary care providers in our organization. And we have about 30,000 Medicare Advantage lives. For those of you who know that managed care, Medicare is what we're working within, and about 30,000 HMO commercial lives as well. We also participate in the Next Gen ACO with CMS for fee-for-service Medicare patients as well. So we do have fee-for-service Medicare also in our population, although our primary focus is working within a capitated global payment type of environment. And that's important because we see that as really an opportunity in that type of environment where pharmacists can really demonstrate their value to an organization. And we have been in existence for quite some time, but the first pharmacist was hired at Desert Oasis in 2005. And so over the years, we've been able to grow our programs to the perspective of now that we have 24 full-time pharmacists in our organization. We also support students from pharmacy schools and also have residents here. Over time, we've been able to grow our collaborative practice agreements in a variety of areas, starting with anticoagulation as our first chronic disease management program that we gained responsibility for, and we've been able to demonstrate capability in managing other focus over the years that really piggybacked on our initial success with the anticoagulation service. I just want to make a note that we are part of a larger system of sister medical groups for Heritage Provider Network, and we are happy that we've been able to help develop these programs and then scale them to our other sister groups, which is really part of our mission and sharing this information with you today, that more pharmacists could work in a medical group environment and really demonstrate some value to the organization. So our timeline that we wanted to include here was really to show that the development of these programs, when we describe them to people, they say, oh, geez, 24 pharmacists, there's no way I could get 24 pharmacists at my organization. That's a deep investment. And so we want to show that these programs were built and developed over a period of time, persistent enthusiasm, demonstration of outcomes, and then development of new forms and ways in which the pharmacists are working with patients. But this certainly wasn't an overnight thing. And so we want to encourage everyone, wherever you're at, if there's not a deep pharmacy investment currently, you need to start somewhere, and that the sky is the limit, only going up. One thing that we want to always make everyone to be aware of is one pharmacist alone cannot save the world, and so we always want to encourage adequate support in developing these types of programs. Pharmacists should never be doing clerical work, and so they need clerical administrative support when pursuing these roles. Also, we have really been and we're going to talk about that in our program, of leveraging technology and how technology can really be a pharmacist partner as more things are being developed in order to touch and improve the care of more patients. And also, you need the support of leadership, senior leadership in your organization. And of course, we're advocates as much as having pharmacists have a seat at the table, and senior management is very important, because oftentimes the voice of the pharmacist isn't present, and that's how we might not be getting the availability to create change and improve care for patients if we're not there at the decision table. One of the important things or challenges that we faced in rolling out our programs is scalability. We're always challenged with how many patients can a pharmacist impact, and that goes back to the role of how technology can help us. And the very important part of when you're embarking on a disease management program is what is it you need to measure? Starting with what the problem was or the issue that arose to develop whatever program the pharmacist might be working on, is how can we measure the impact of that and demonstrate outcomes. And that's very important because, as we know in healthcare, there's a lot of competition for resources, and everybody wants to have a piece of that. And there's always a push to have things be done as efficiently as possible. And commonly, pharmacists are looked at as expensive investment, and they are. So we want to always try to do whatever we can to demonstrate the value of what we're doing. It's preaching to the choir. We know the benefit of better use of medications and optimizing that, but showing that within the system, I think, has been a challenge for pharmacists. But we know that increased focus on this is really vital, and everyone, as you're measuring your outcomes, we need to share that data together so we can continue to make the case of the value of pharmacists and organizations. Okay, next slide is just a quick word about the triple aim. I'm sure many of you listening are well aware of the triple aim, but I just wanted to remark about how this really has created a tremendous opportunity for pharmacists as pressures to improve quality and satisfaction within the system, but also to lower costs. That's a huge challenge for our overall system. What we have found is through the global payment mechanisms or capitated payments or outcome value-based payments, this is the area in which pharmacists have some true opportunity, because what we'll show you with our information is really pharmacists are the path to achieve the triple aim. Our knowledge and use of helping to optimize the use of medications for patients, helping reduce costs in chronic conditions which are so costly to our healthcare system, and doing this in an efficient way is why I believe that the triple aim is really a pharmacist's friend.
All right, so we'll go on to the next slide. Okay, so we understand the triple aim as a goal for the healthcare system and as a country, but I think it's really important for you to evaluate and understand the goals of your organization. These are our goals. So population health and prescription management, also known as PHARM, so you got that correct. We want to make sure that our members benefit most from their medications. That means that they're being prescribed appropriately, there is proper access, and that access may be cost. It might be physical access, difficulty in actually acquiring the medications. It might be formulary management and understanding the formulary. These are all ways in which a pharmacist is uniquely designed to interact with the healthcare system. With our programs, the management of the chronic disease programs really allows for proper accessibility and appropriate use of medications, but it also has additional benefits. And one of those is the ability to send the most appropriate patients for the appropriate care at the appropriate time. An example of this might be our hepatitis C program. In 2007, we began treating patients with hepatitis C. This is back in a time of interferon and ribavirin, difficulty in keeping patients out of the hospitals, reducing transfusions, and getting patients to a really difficult to obtain goal where only 40% of patients were really being treated appropriately for hepatitis C. What we were able to do is take this burden from the primary care physician, because it's a daily burden. It's communicating labs, it's understanding the labs, and keeping people safe on a daily basis, which is often hard for primary care physicians to do. But what it also meant is we could reduce referrals to hepatologists, because the majority of patients with hepatitis C are able to be treated appropriately outside of a hepatology office as long as you have good follow-up and procedures to keep a patient safe and on task. We also strive to improve patient satisfaction, and through conversations with patients and providers, a lot of this satisfaction really comes down to communication between different clinicians within the healthcare sphere. So making sure that the primary cares understand what the pharmacists are doing with their patients in between those visits, and making sure that the patient understands that this is a collaboration across all levels of their healthcare clinicians. They want to know that their primary care knows what the pharmacist has been doing, has an understanding of that. A good example would be the patient you're treating for diabetes. You're managing their insulin and their other diabetes medications, and the patient goes to their primary care for an upper respiratory infection. Well, that primary care really needs to be in a position to know what medications the patient's currently on, and the patient likes to know that the pharmacist has communicated those changes to the primary care physician. So communication is really key to that patient satisfaction and really connecting the transitions of care that happen every day in the healthcare system. So we can go on to the next slide.
So really what I wanted to talk to everyone about a little bit is how demonstrating the value of pharmacists as collaborators. We might be preaching to the choir on this, but I know when we speak to people around the country about this, they're not always familiar with pharmacists in terms of collaborative practice and what that actually means and how a pharmacist might be valuable in that situation. What we know about chronic conditions is they are largely managed through medications and the optimal use of medications. We know in our country that oftentimes medication outcomes are not being maximized, problems with adherence, problems with patients getting access to medications, possibly by cost issues, patients understanding their medications and how to use them. Also, then the side effects of medications and how to mitigate those. Really, chronic conditions and the high use of medications in those, pharmacist training is key to helping be successful in this realm. And so that's why we want to make the case to our health systems in the country that having pharmacists be a part of this process can be a very valuable thing, and that's why it's important as we're trying to demonstrate our positive outcomes that all of you out there that are doing this type of work are doing the same and sharing. I think that just an editorial comment is pharmacists need to own that they are medication experts, and we need to work to ensure that we do have a seat at the table. So next slide, collaborative drug therapy management. What does this actually mean? Really what 48 out of 50 states have collaborative drug therapy management statutes within their states for pharmacists. We want that to be 50. But what this really means is the pharmacist being able to work with patients in between visits with their primary care physician to manage chronic conditions. And people are often surprised that in this realm, pharmacists can work independently. They have a protocol that's been agreed upon in the health system with the physician and others within the health system. But the pharmacist works independently, performing services. It's very important that the physician supports the use of the pharmacist to work in between visits with the physician. If the physician is not supportive in endorsing these programs, they will not be successful. So the partnership with the physician is so very important. In this realm, pharmacists can change medications, add medications, order drug tests. So changes are made. These aren't recommendations, and I think that's an important thing is when pharmacists are recommending changes, we have had programs like that in the past before we embarked in our collaborative drug practice programs here. Recommendations might not always be accepted or implemented, or there's a delay in in doing that, and that kind of blunts the outcomes that you can achieve through the contribution of the pharmacist. So the key to this is changes are made, and then those changes are communicated back to the physician or primary care physician in a very timely way, so that everybody's on board and understands what's been done with the patient. And so that way, if the patient then presents later to the primary care office, they're informed and everyone's working together. It's very important. All of our protocols are guideline-based, evidence-based things that we are promoting, and that really helps drive the quality of care within our organization. It's important to note that when working in a collaborative protocol with a patient in collaboration with a physician, is we don't want to be having blinders on. The collaborative drug protocol is a way that we are now able to work with a person, a patient, but we're trying to teach our pharmacists that we're still using big picture thinking when seeing a patient, because now that's our opportunity to possibly identify other issues or problems the patient might be facing in order to connect them with our system sooner to other help that might be needed, for example, social work or some other clinical problem they might be having that's beyond the scope of what the pharmacist could handle. But them able to refer quickly to those other people is one way that we help early address issues and further support the idea of saving costs within the system. So we don't want to be working in a silo, so we're always trying to prevent that. So communication back to the primary care physician is definitely key in this process.
All right, so we'll move on to the next slide. Our organization, like many others, has their own frustrations, and that might be cost, access, communication, it might be your EHR. Identifying those frustrations is key to understanding what the pharmacist can do in collaboration with the organization, as well as the other clinicians, primary care physicians, and providers to make an impact. And that's really how we've come to the point of PHARM, is each of these little bubbles is really a place of frustration. We're going to go through each of these programs, really talk about what were the pain points, what led us to intervene in that particular disease state, and what were the outcomes from our interventions, because it's important with anything that you're doing to be able to have a baseline understanding of what the problem is, be able to define it in a very objective way, and create systems that allow you to show your outcomes and improvements in an objective way after you've made that intervention. Next slide. So when we looked at all of the different communications that we had been sending to primary cares, our organization, clinicians, this is really the word cloud that came from it. And you can see the biggest impact that we want to make is outcomes through collaboration and protocols and pharmacists. We'll move on to the next slide.
Okay, so looking at this implementation workflow, this is really set up a recipe of approaching a problem within your organization and developing a collaborative practice protocol to improve the care for your patient. So what we found through iterations of this in various ways is there seems to be a formula or recipe for success. So the first part is identifying the opportunity. What we have found to be best, or really a good start with this, is when the opportunity is brought to you by someone within the organization. So it isn't always the pharmacist team bringing up an opportunity of something that we think we can work on. It's really great when the leadership at your organization, medical director, primary care physicians come forward and say, we're having this problem and we really think that the pharmacist could be helpful in working with this group of patients. When those problems are brought and arise, that's when the pharmacists sort of spring into action and say, great, now we can work on what is it that we can do to help these patients. And a lot of times it resonates with us because, again, these are all about chronic conditions in ways in which we can help better use medications to improve the care of patients. So next step in this implementation workflow is developing a collaborative practice protocol, and that's going to involve interdisciplinary teams. It's really important that you involve all the players within your organization in all your disciplines to help review the protocol and develop the workflow of how it's going to be implemented. So this will be your nurses, frontline staff, physicians within the organization. And what we have had happen several times is having a champion physician who serves as sort of the pilot, the early adopter that is able to be the first advocate for how the program is working, how the protocol is working, how the patient, that process of working with the pharmacist with their patient has turned out. As you have that endorsement of that champion physician, that then leads to the ability to scale the program across the organization. And that's been a really important aspect of the programs that we've developed. The next thing is people want, physicians and providers within our organization love having a medical director, a leader who is mentoring the pharmacist. Because if you are a primary care physician and you're delegating out an aspect of care for the pharmacist to manage, going back for decision-making always the primary care physician might not be the best way to do it if you can have an expert in that disease state for the pharmacist to have as a mentor. For example, if our COPD program, we have a pulmonologist who the pharmacists are working with directly for complex patients and developing patient plans. Endocrinologist in our diabetes program, or a cardiologist working when we're working in cardiovascular conditions. So having that expert physician as a mentor has served to drive acceptance of the pharmacist collaborative practice programs within our physician network, and help to have the pharmacist decisions, have them learn in the process and get more and more effective at what they're doing in working with patients. And that's really helped to drive success. The other next part of this, might have got ahead of myself a little bit about that, but that the protocol, as you're developing it in an interdisciplinary way, is having it then go through being approved and determining what you're going to measure, how the outcome is demonstrated through the benefit. Are we reaching goals for patients? What is our admission rate for the patients that we're managing? What is readmission rate for those patients? What are the costs? How are we affecting medication use? All of those things are important things that we're measuring with any of our programs to help demonstrate success. And then, of course, there's the patient satisfaction, physician satisfaction with how the system is working.
Okay, so we'll move on to specific examples that we've encountered in our own organization. Anticoagulation was the very first CDTM pharmacist-led program. That was in 2005. Prior to the pharmacist engagement in this program, you had a nurse-run program under the guidance of a cardiologist, and their process was the nurses were the primary management, but of course had to go back to the cardiologist for decision-making on dosing changes. Because of that, we had a population of about 300 patients in that program. And knowing the size of our population in the medical group and understanding the percentages of the population that should be on an anticoagulant, we knew we weren't fully capturing all of the members who were on an anticoagulant. At that time, that was warfarin. So a pharmacist, Teresa, our very first pharmacist, was brought in in 2005 in order to allow for independent dosing under the guidance and leadership of a cardiologist. In addition to that, we started using a technology called Dawn AC. It's a predictive modeling tool, and if you can imagine a system that learns over time. When additional INRs and scheduled dates are put in, it can then predict and give you a suggestion on dosing in the next scheduled date for an INR. Still requires somebody who has an understanding of pharmacokinetics and dynamics, such as a pharmacist, but it allowed to shave off probably between 30 and 40 seconds per patient. And the result was, within a year, we were able to increase from 300 members in our program to 1,000. And at this point, we have somewhere between 3,300 and 3,600 patients active with our anticoagulation program. And now, of course, that includes not only warfarin, but the DOACs as well. The question became, okay, now we're capturing the population that we want to see. We know our therapeutic time and range is about 70%, which is gold standard. But what has it actually done for the overall outcomes for the organization and these members? What have we done to avoid ischemic and hemorrhagic events? What does that mean for cost to the organization and the overall healthcare system? And of course, these are all difficult numbers to find and define and determine our role explicitly. For this data, we went back to the literature and were able to take the financial analysis that was done in a 2005 CHEST article done in Colorado, and apply the metrics in that financial analysis to our own population. And we were able to show not only were we able to avoid events, but that really came to a little over $4.5 million in savings. Now, anticoagulation was a good first choice because at that time, pharmacists were really accepted in managing this type of chronic disease. It had been done at Kaiser and the Veterans Association, and so it wasn't unexpected for pharmacists to be in that position, and it really gave us our leg into CDTM at the organization. Fast forward to 2009, we can move on to the next slide, came diabetes. And this was at a time when HEDIS and STAR measures were starting to come to fruition within medical groups like ours, and we were being held to a nationally recognized outcome. Our surveillance rates of A1Cs were great. We were easily at 90% surveillance, but our control rates did not match that. So the question came from the organization, could pharmacists do with diabetes what they had done with anticoagulation and hepatitis C? Could they take the time between physician visits to optimize diabetes care? And we applied, much like Teresa mentioned earlier, we applied the implementation workflow to diabetes management. As you can imagine, there were many physicians in the organization who were reluctant to allow somebody else to manage the care of their diabetes for their patients. Questions such as, whose liability will it be if one of my patients shows up in the ER with a hypoglycemic episode or DKA? And the truth is, when you're in this sort of program doing CDTM, the pharmacists do have to accept some liability for the patients they're managing. They have to have the same level of skin in the game as the primary care physician. So that was our message. We started out with a champion physician who had a large panel of patients. And given a large panel of patients, there were a large number of diabetics as well who were uncontrolled. He allowed us to manage his patients for 6 months. We came back with impressive data in terms of improvement in A1C, lipid, and blood pressure values. And we then took this to our organization, and we have both IPA and group or staff model physicians that are employed by the medical group. So our group physicians said, yes, we will work with the pharmacists to manage diabetes. We did this for another 6 months. Again, our data showed that there was a vast improvement in the diabetes care for these members, given the intensive time spent by the pharmacists and their knowledge of medications and disease state management. Now we have all of our physicians, over 100 physicians within the group, who regularly refer members into our program who are poorly controlled or who have had utilizations. And what we've been able to show is, and this is data that was done in collaboration with the USC Center for Health Policy and Economics. And we were able to show not only reductions in diabetes-related hospitalizations, but also all-cause hospitalizations. If we move on to the next slide, We can also see that we were able to show a large reduction in A1C, lipids, and blood pressure for not only our senior, but also our commercial or younger working patients. And I'll talk a little bit about technology and how technology's played a role. But all of our programs are designed for the right patient, right care at the right time, which means that once we get them to their outcome goals and we feel that they've gained the education and understanding of their disease state, they're returned back to their primary care for us to take on poorly controlled patients. So on average, we have about 5,000 members that we're managing at any one given time, but that's a dynamic number. It goes up and down as we bring on and discharge patients. The question remains, was there sustainability? Could we see the same level of control of diabetes even after the pharmacist is no longer actively engaged in their care? And what we show here is that up to 270 days after they were discharged from our program, they still maintain A1C levels at control. So that meant that what we're doing is patent. We do see some members come back to our program, and I guess they're happy to do so. We have asked the question, how many patients would recommend this to friends and family? And 100% of our patients said they would. So that was 2009. We've been managing these patients for 10 years. And in 2013, we'll go on to the next slide, the question came to us, we're seeing a lot of utilization and reutilization of COPD. Our patient population, our senior population, is about 15 years older than what you'd expect in the regular population. We're a retirement community, and so COPD was something that was a concern for the organization. Again, we have what is the problem in the organization, finding the issue so that the pharmacists have something to go in and solve. So we were asked if we could do the same with COPD management. And this became probably our first very interdisciplinary program. We introduced pharmacists and a respiratory therapist, as well as a pulmonologist into the program. We recognized that not only was drug therapy and access really important, but we also had a very large component of education on use of inhalers and treatment medications, and also things such as exercises and breathing techniques to improve anxiety related with COPD. So the respiratory therapist was really a very important addition to that program. This included face-to-face and telephonic programs, as well as a 3-hour workshop that our patients are required to go to. All of our programs are free. They don't require a copay to see the pharmacist or anybody within the disease state management program. And access, again, is the goal there. We want to make sure there are as few barriers to us impacting patients as possible. So if we move on to the next slide, you can see that we looked at this data in a couple of different ways. First of all, we wanted to look and see what was our hospitalization rate before we started, and then we wanted to look at it on a very consistent basis, 6 months, 12 months, and what we were able to show is not only did we reduce hospitalizations, we reduced readmissions. So many of the patients that we get into our clinic are a result of a utilization, and our goal, of course, is always to reduce unnecessary admissions. And we were able to show in the first 6 months of the program that we reduced those by almost 17%, and then in the second 6 months, we had an additional 14% reduction. And of course, for the organization to continue to support pharmacists and grow the vast number of diseases that we can manage, we want to show that we have a significant financial contribution to the organization, and we were able to show that. Teresa alluded to this in the beginning of the program, that pharmacists in this environment uniquely allows them to have an impact on patient care. Because as the rest of the nation is really struggling with how do pharmacists get reimbursed for their ambulatory care services, in a managed group under capitation and global payments, we can really see that it's not so much reimbursement as it is cost avoidance. So it's another way of looking at how pharmacists are valued above and beyond the clinical outcomes that we know we can provide. And if we move on to the next slide, you can see another representation of COPD's impact on utilization and readmissions, 30-day readmissions. So it's important to be able to have the data to show to the organization your impact. And I know for us, data analysis is not always easy. We were trained as pharmacists. We have a certain level of understanding of data and whether we can believe a clinical trial and whether we believe it to be valid. But when it comes down to generating the data in a reliable way, you really need to look to other partners. We have a partnership with many different schools of pharmacy. We take their students, and in return, that gives us the opportunity to work with them and their resources to analyze our data. So that's another important key. Don't simply rely on what's available in your organization, but seek out other opportunities and build those relationships in order to be able to show your improvements and your successes. We'll move on to the next slide. Technology. So we've referred to this in a number of different areas, and technology really has become our extender. Pharmacists are an extender of the primary care physician and the specialist, but at some point, in order to reach the population that we need to manage, we need to have an extender as well. And technology serves multiple different goals. One, we have a number of different types of patients. We've got your senior patients who are retired, who like to come in. They do health education as a group. It gives them that social interaction. But then you have those frail seniors who are unable to leave their home. You have commercial younger patients who are still working, and their hours of work are the same as our hours of operation. So it makes it difficult for us to connect. There has to be more than one way for us to be able to see how a patient is progressing and be able to touch them. Technology has proven to be very beneficial in that aspect. So here's an example. I'm going to give you a few examples from patient adherence mechanisms such as Proteus Discover. This is a tool that allows you to electronically tell if somebody has ingested a medication and give you biometric data fed to you cellularly in order to reduce the need for patients to come in. So it gives you that view on a daily basis. We can move on to the next slide. Remedy is very similar in how we use it to Dawn AC. It's a predictive modeling tool for diabetes. So it allows us to take in blood glucose levels on a cellular level. So we provide our members all cellularly enabled glucometers. That means when they're at home or out in the community and they test for their blood glucose, it transmits through the cloud into our system instantaneously, does not require Bluetooth connection, a smartphone, and that's an investment that we've made in our members. Because we're a medical group and we're at risk for much of the medical cost for our patients, many of these patients will already be required to get their diabetic supplies directly from us at our cost. So as an organization, Pharm is the provider and distributor of diabetic supplies. And it made sense for us to make an extra investment in our really high-risk diabetics in a glucometer that allowed us to see the blood glucose levels on a regular basis. Now, Remedy takes those blood glucose levels along with their medications, allows us to make changes in vitro in the system to their medication doses, and predicts what their blood glucose levels will be with that change, in addition to predicting their A1C. We did a pilot with them, a trial to see what was the impact of on our patients' care for diabetes, either with standard of care with a pharmacist versus standard of care with a pharmacist and the tool. And we were able to show that with the tool, a pharmacist was able to get a patient to goal faster and to a better goal than they were with just the pharmacist alone. We can move on to the next slide. There was some other goals that were hit as well. Expect it because the tool doesn't really focus on lipids, but those patients who were on the Remedy tool had a greater reduction in LDL than even just the pharmacist with the patient. We're not really sure why that occurred, but I think technology gives you a greater feeling of connectivity and communication with your patient than having them out in the community without that regular daily touch. We can move on to the next slide. And I think it's worth saying, you know, we compared a lot of these technologies to our standard of care with a pharmacist. But what's really important is to also be able to tell the story, as we did in the previous slide, that standard of care with a pharmacist was able to reach goals above and beyond standard of care with the primary care physician. Now, this talk obviously is not about comparing pharmacists to physicians. It's about that collaboration and the inclusion of additional team members based upon their expertise. You're adding a pharmacist's expertise on medication to the already diagnostic expertise of the primary care physician to reach a goal above and beyond what you would have with the primary care alone. Surveyor Health is a tool that really predicts the risk based on drug-drug interactions and allowed us to communicate those risks probably a little more clearly to our primary cares. So as you can imagine, if you go in and run a drug interaction list with 10 medications, you're going to get a myriad of interactions. This tool really helped us to further understand the importance and the impact of each of those interactions. Not all of them are necessarily clinically relevant, nor do they need to be acted upon. You really want to know which ones do you act upon. And this tool gave us that ability when we're doing our med reviews for those that were delegated by the health plan. We can move on to the next slide. Adherence is a huge focus of our pharmacists because we recognize that our value is really in having patients have access to their medications, but also use them. If they don't use the medications we're prescribing, our value is very little. So Propeller is a tool that we started using in February of 2017. It's a sensor that can go on Respimat, dry powder inhalers, HSAs, and it will actually tell you when there's been an actuation. That goes directly into our platform, and it can predict an exacerbation up to 10 days ahead of time. So that tells us if somebody is using their rescue inhaler too often, if they're not using their controller enough, and it helps us to define who's the right patient to communicate with today. And I know that's the problem probably for all those listeners, is understanding who is the patient you need to touch today. Sometimes it's obvious. Sometimes they're the one coming out of a hospital. They're the ones that has called you with a problem. But so often there are people at home that we're managing who have a problem and don't call. So using tools that help us to identify who we need to touch that day, who is most priority, and that's a big part of why we use technology. It allows us to passively prioritize patients. Okay, so we can move on to the next slide. All right, so what are our keys to success? I think we have to understand from the perspective of the patient. The patient trusts their primary care physician. That is their leader, their driver of healthcare. It's the person they've called whenever they have a healthcare need. So that means that their primary care really has to trust us as the pharmacist, has to trust our management, has to trust that we're going to be communicating with them. We have to trust that they're going to reinforce our treatment plans and essentially back our role in their patient's care. So building that trust with the PCP or the primary care is really key to maintaining our role in chronic disease management. This has to do with communication, document sharing, use of the EHR to its maximal capacity, making sure that the primary cares understand the volume of patients that you're managing for them and what the data has shown to support your role. When you can have an active interaction with a patient's primary care physician, everybody wins. The patient, the primary, and the pharmacist, as well as the organization and the overall healthcare system. We can move on to the next slide. Carpe diem. It is our time to seize the day. Pharmacists have a unique knowledge base. We have the evolving roles that we're being given state by state. We really need to seize today for the day we get a seat at the table, we become part of the interdisciplinary team, and we go beyond knowing what needs to happen to our patients and their disease state management to doing what needs to happen with their disease state management. So find the need in your organization. Identify the holes that need to be filled. Find the places where there is a need and seek out what the need is through data. Speaking objectively about the need, communicating that to your organization and your patients really provides a platform of objectivity for you to express the role of the pharmacist. Integrate into the system. Gain the trust of your primary cares, your nurses, your interdisciplinary team. Gain access to your EHR for your system and use it to its maximal benefit. And use it as a communication tool to the others in your interdisciplinary team. Find your partners in your primary care. Find your champion physician or your medical director as it relates to that disease state. Pulmonologist for COPD, endocrinologist for diabetes. Find your partners that can speak to the entire organization on your behalf. Go slow, then expand. We started with one program. We started with one pharmacist. You don't need to start with 25. Identify a problem that you can tackle with 1 or 2 pharmacists and support staff and really show the benefit, and then expand to other areas that you know need help. I know that it seems daunting, but we were the first organization within Heritage Provider Network to have a pharmacist. And now in each organization, you see pharmacists participating in chronic disease management, utilization management. They found areas in those organizations where pharmacists can flourish, and they've begun to expand. So in the last 15 years, we've gone from one pharmacist servicing over 500,000 patients to well over 50. Revisit your data. What have you done right? What can you improve upon? How can you expand into different areas? It's all based on that objective data. Make sure you know what access you have to data and what's invalid. Find partners in educational organizations, schools of pharmacy, other nonprofits in your area, and visit your data often. And then repeat this whole process as often as is needed. Carpe diem. It's really our time to be a seat at the table. Next slide. The sunrise of our day as a pharmacist. This is a beautiful picture here from the Coachella Valley. Just wishing you all success in your endeavors. Thank you so much for joining us.
Thank you.
Well, Lindsey and Teresa, thank you so much for joining us today and sharing your story. There was a lot of really good data and a lot of great information that you have shared with us. We've had many, I'm pausing our screen so that way I can pull up our questions. We have many questions that have been coming through. We probably don't have time for all of them, but I'm going to try to read as many as I can and then start sharing them with you.
Well, that's wonderful that there's some questions. That's exciting.
Yeah. So I think the first one is a really good one. And again, I'm going to just kind of pass it to both of you at the same time, and you can kind of flip a coin for who's going to answer it. But our first question is, how do you coordinate disease management programs for patients with multiple comorbidities?
That is a very good question, and that is something that we have also struggled with as we've gone through the process of adding additional programs. So you can imagine the patient who has diabetes, COPD, and cardiovascular disease. Patients really want to have a driver of their care outside of primary care. They want to make sure that they don't have to talk to 3 different people about 3 different disease states. So one of the things that we've focused on is continuing education for our pharmacists and shifting our pharmacists to different programs. So while they might have an expertise in a certain program, allowing them the opportunity to shift into another disease state in order to gain an expertise. We have a system where you would have a pharmacist who normally handles COPD, but if that patient also has diabetes and CAD, they're managing all of those in the same call. But I think what's also important is then communicating all of those changes to the stakeholders for that disease state. That might be a case manager within the organization who handles some more of the logistics and psychosocial, social determinants of health issues, or the primary care physician or the specialist. We also put a heavy emphasis on getting our pharmacists board certified and advanced practice licensure. The reason for that is those of you in the audience who have had to go through that process is the continuing education required. So I think that it's really important to stress to your teams the importance of providing continuing education and access to education to your pharmacists.
Yeah, speaking to that is just we expect a pharmacist to have expertise in all of these chronic conditions that builds over time through doing the work. So we want to do everything we can to keep our pharmacists here so that they can continue to hone their expertise to manage patients across all the different disease states. And I also think a electronic medical record that integrates information from enterprise-wide is very important. So that's something that we do have here with our physicians. Most of them are managed through electronic medical record. Many of our specialists are there. Case management is there, as well as our farm programs. So we're able to, talked about the silos, break down silos as much as possible and see things more from a global perspective. And the talk about board certification is really important because, you can't just be looking at one thing. You have to be able to have an expertise to anticipate problems and help patients on all the variety of things you're dealing with on an ambulatory care basis. So it is a great question because that's a great challenge. And I think some of the criticism in the past of pharmacist collaborative practice is that we work in a silo where we're only focusing on one thing. And so we work hard to break that stereotype and not see patients and managing patients in that way. It's definitely a challenge and something to keep challenging your pharmacist to not get pigeonholed in that way.
I will say one last thing on that question. I understand that some of our audience might be really focusing on one disease state and may not have access to collaborative protocols for the myriad of things that they might encounter with their patients. If you have access to a shared EHR, documentation is key, and sharing that documentation is important. I think also going back to the primary care physicians with a plan so that they understand your expertise in that area allows you to make a bigger impact on those disease states that you might not have collaborative practice over.
Awesome. Thank you very much. And what's really fun is in answering that question, you actually answered some of the other ones, which are like, how do you ensure that pharmacists feel comfortable or the credentialing to manage these various medical conditions? So kudos for a 2-for-1 without even knowing it. Another question that I'd like to, another question that I would like to share, because I think that this is a different perspective and one that's really exciting, is one of our listeners today says that they are a nurse within a disease management group helping care for patients with chronic kidney disease and end-stage renal disease. And so they wanted to know if you had any experience with that. I'm not quite sure if they're referring to CKD or the interdisciplinary with nursing, but if you want to speak to both, we've got maybe a minute left or so.
Sure. And actually, that is something that we deal with on a very regular basis. Not only are you going to interact with patients in your collaborative practice who have renal dysfunction and perhaps even dialysis, but we have a program here that is nursing run, and they oversee our ESRD and dialysis patients who might not be in another program. So there are occasions where those nurses are interacting with a patient that we're also managing for things such as diabetes. And I think what it takes is a lot of collaboration between the two. One, we want to avoid over-messaging to patients. Two, we don't want to be contradictory. We want to make sure that the nurse case manager, the nurse overseeing that disease state, as well as the pharmacist, are on the same page, and so the patient feels confident in the communication. But I also think one of the most important things is having that team that recognizes the benefit to having both a nurse and a pharmacist on that case. The nurse provides so much insight on the patient's physical well-being and assessment to the pharmacist that they might not have available to them. So really working as a team, recognizing everybody's strengths, and communicating to the patient in a uniform front is really important.
And there's been a lot.
Thank you very much.
Yeah.
I'm gonna have to be the gatekeeper today and say that we're running out of time. So that is all the time we have. Any unanswered questions are going to be sent to Teresa and Lindsey for their response. So thank you again, Teresa and Lindsey, for joining us taking the time to present this great information. I want to remind all attendees that you will get a brief survey when you exit out, so please be sure to answer that, and that all recording and slides will be distributed within the next week, and they're going to be available on our website. Additionally, I want to remind everybody that we do have 2 upcoming PQA events. We have our Caring for the Whole Patient Social Determinants Forum, where we're looking at leveraging pharmacists to address social determinants of health. Additionally, we have our PQA Leadership Summit that immediately follows that Social Determinants of Health Forum. If you have any questions, please visit our website where we have more information on both of those exciting activities. And then until then, we look forward to seeing everybody again in October for our next Quality Forum on Thursday, October 3rd. Again, I hope everybody has a wonderful day, and thank you so much for joining us this afternoon, or in the case of Lindsey and Teresa, this morning.
Thank you again to the PQA for this opportunity. Much appreciated.
Thanks all.